So should I begin? We are ready.
Yeah.
A
Okay.
very good evening, everyone. I, Dr. Misbah Kadri and Shubham Bharti will be the moderators for today's session. We welcome you all to the Cynodent International and Indian Society of Dentistry webinar series 2023. Theme of this series is Unlocking the Trends in Dentistry. For today's first session, we have with us Dr. Nikhil Verma sir. He is the principal and HOD at Gitanjali Dental and Research Institute, Udaipur, Rajasthan. Sir is also a member of Dental Council of India. Topic for this session is failures in FPD. I would like sir to please start with the presentation.
Good evening, everyone. So thanks, Ms. Kadri and Shubham and Anmol for sharing a good platform to me. And Cynodent has already been working very hard to, pursue dentistry in the brains of young minds. So that is a very good attempt by them. And webinar, where everywhere the webinar has been closed down, they are still pursuing with the webinars. Even I feel that that is a good source where, the system can reach you on your laptops and in your mobiles, and you can hear to a good speakers and good mentors, and you can refine your practice. So there's a quote by, Winston Churchill, who was the Prime Minister of that time, UK, United Kingdom, when it was a war with Germany in World War II. Okay. And success is not a final, failure is not a fatal. It is the courage to continue that counts. But in dentistry, there's something called as herodontism. We are not supposed to do that. You don't try to be hero in dentistry. You always try to be, very frank to the patients. Patient is going to come to you with a lot of hope, a lot of things in his mind, in her mind, and he's going to think that, this man is going to give me something which is going to last long, and the probability factors is there in the patient's mind when he's coming to you. Okay, patient might walk in with a fractured tooth, patient might walk in with a diastema, patient might walk in with a discolored tooth, patient might come with this kind of attrition teeth or missing teeth, or this is the last one is the orthodontic failure where the patient came to me and she's just 25-year-old girl or 23-year-old girl. I'll show you this case also. A patient coming to you and he's all excited to show you his teeth. So, uh, if you're going to do this kind of work, I don't think so. Uh, and you cannot blame the economy part of it. What young people are doing is they are practicing cheap dentistry and then blaming the patient ki, whatever money you've given, we can do that only. Charge your patient, please charge your patient, because charging your patient will give you a better scope to practice. And if you are full, then definitely you can do a better job. Okay. So in young practitioner or who are the established practitioner there or postgraduate students are listening to me, please charge your patients. Okay. Charge your patient well so that he can do a effective job. You cannot practice dentistry or a FPD without doing your addition silicone. You will have to take a rubber base elastomeric impression material, that to addition silicone only. You will have to send it to good lab. You will have to do for a dye preparation. You'll have to, follow up your cases, and you'll have to see that that you give a good things to the patient. So these are not a good FPDs, monolithic kind of presentations, a simple color hai. Okay. Now, patient, when they come to you, the straightforward question with patient in various treatment procedures going to ask you, "Sir, kitna chalega?" And that's the Indian tendency. It's not an Indian tendency, it's everybody's tendency that, when we buy a thing, we need a prediction of it. Okay. And that prediction is about the years. And he's right in that question. You cannot answer that, I cannot answer you. कि भाई देखो हम guarantee in this. He's not asking for a guarantee. Okay. And don't give you guarantees in your clinical practice. No guarantee. Lab is giving you guarantee. Don't pass on to the patient. Don't start the trend of giving the guarantees to the patient. Patient is going to ask you something which is going to be, it's a prognosis. Okay. He's actually asking you a prognosis. And any case history procedure has a last word, which is called as prognosis. And this is a meta-analysis where various articles were taken and, various research for topic. were taken, and it is a 1994 article. Okay, and it was meta-analysis was done. We'll discuss it. They last line says that they calculated overall survival rate was 74 plus minus 2 years after 15 years. Okay, so 15-year survival rate they were saying, but we don't know what FPDs were done. Okay, they were metal restoration, they were PFM restoration, or they were, I mean, 94, the zirconia wasn't evolved. Okay, they were alumina restorations were there. This is again an article of 2004, I think. Yeah, 2004. A systemic review of survival and complication rates of FPD after observation period of last at least 5 years. So 5 years follow-up they had done. Okay, this article again it says that pooled data, you left side, if you see the study year, there was 2002, 2003, 2002, 1997, 96, 93, 92. Okay, so all were done before 2004 only. And they pooled up data. So total number of FPDs were given as 2,880, 81. And the failure rate, which was predicted, okay, you can see the follow-up years also 6.3, 7.6, 16 to 18 months only. Sorry, 16 to 18 years, and 10 years, 6 years. The pool data was of 2,881. And in that, you can see that 374 FPDs were a failure. Okay. And the confidence interval for that was, 95%, 95% common, your confidence interval denotes that when you take a mean, mean, mode, median, okay, and the standard deviations are there. So confidence interval is of the two-step of the standard deviation from the mean data. Okay. So confidence interval is 95%. It means p-value is really, really good about it. Okay. P-values must be 0.05. So that's a very significant data to quote that your FPD should survive for minimal 5 years. Okay. I mean, they've quoted for 10 years also. Okay. Now that was the survival of conventional FPD. Now you can see that the loss of FPD due to periodontal diseases. So that if you say the confidence interval was 95% and the pool data was 1080, okay, and the FPD loss due to periodontitis was only 7. Okay, this is the very, very good data to share. Again, the mean follow-up time was almost, ranging from 7.6 to 18 years. Okay. Caries and loss of abutment validity were the most common biological complications. So, when patient comes to you after a long period, 2 years or 3 years, okay, and if your margins are really good, if you use a good lab, you use a, dye preparation and was done, your margins were really good. Okay. So caries and loss of abutment vitality is going to be very less. Okay. But in common clinical practice, what I have seen is uh, patient coming up a follow-up of 10 years, okay, and the patient is of a younger age, okay, patient is of 35 years of age or 25 years of age, and you gave a FPD and you did a follow-up of 15 years, that becomes really very, very easy. So age is not a factor which is being discussed here. And all the article, all the data are discussing about the data of the patients, not of the age related. When I see a patient coming to me out of 65 years of age, and if I see a follow-up of for 10 years or 8 years, okay, I have seen that there is a caries. That caries wouldn't have been there before. Okay. So the data might be, age related also. Okay. So try to give a good margin. What bottom line is, caries is going to be there in the patient mouth. Okay. At a younger age, caries fighting capacity of the salivary immunoglobulins is going to be very high. But as the caries, I mean, as the age advances, the salivary immunoglobulins are going to be very less. Okay. IgG is going to be very less. So the fighting capacity of the saliva against the is going to be very less. Okay. So for that, we need to really take care of that. You advise the patient 3 months or 6 months follow-up. Okay. Effective brushing techniques. That all I'll give it in summary. Okay. So loss of abutment tooth vitality, the pool data was 1318. Okay. And number of abutment that lost vitality was 168. This is again, it's a government data. Okay. 168 number is not a, data which can be ignored. Okay. Most common fixed partial denture complications. Okay, that is the good care et al. They had given. So out of 3,360, there were 602 abutments had, they were caries were there. That is mean incidence is 18%. Okay, And in need of endodontic treatment, well, it was 11% of the abutments are needed. Okay. And loss of retention was 7%. Now you see, loss of retention is only in 7%. Aesthetic failures was 6%. Periodontal disease is 4%. Tooth fractures again 3%. Prosthesis fracture 2%. Porcelain veneer fracture is 2%. Now, porcelain veneer fracture, prosthesis fracture, tooth fracture, okay, these were the end related control. Means the control was on your hand. Okay. Periodontal diseases, again, the control was in your hand, that what kind of FPD and what kind of Pontic did you give to the patient. Okay. But caries was not in your hand. Okay. If you have given a good margin, then caries was not in your hand. But caries can occur due to the patient related causes also. So there, the oral hygiene has to be in control. There's again, article in JPD, which was published in 2021, and which 10 years follow-up was done. Okay. And survival proportion for the examined was FPD was 74%. Now, 10 years, 74% survival rate, 25% went wrong. Okay. Now, 25% went wrong. Their labs are really very good when they are doing this kind of studies. So I'm that these are the institutions which are doing the studies. These are not the person who's doing a study. So the institutional labs are really very, very, very good. If we have our own follow-up in a city called as Udaipur or wherever you are practicing, I think the failure rate will go to more than this of a 10-year follow-up. Okay. The end controlling factors we are going to list in this summary or in this presentation. We're going to think about it. We're going to go through about it. Okay. So this 74% is a very good survival rate if you say so. But the promise cannot be delivered to 100% patients. Okay. So you cannot say that, FPD, what you've done is going to survive for long. Okay. There are end controlling factors for you and for the patient also. So don't promise anything to the patient. You can just quote the figures that, a survival FPD of 10 years, 74% cases are into good FPD if I've done it properly. Okay. So again, from here, the transition to this place is really take time. So how are FPDs made fail? Okay. So there are failures can be simply classified, and this was given by Donald F. Fisher and William W. Morgan. And they can be biological, mechanical, aesthetical, and psychogenic failures. Patient कहता रहता है मेरे को, I feel that मैं जैसे खाना नहीं खा पा रहा हूँ. I have some problem on the right side, or I have problems on the left side. You evaluate and you're not able to diagnose anything. Okay. So those can be sometimes, very rarely, psychogenic failures also. Okay. We had given an implant restoration to the patient, and everything was fine. High point was fine. Everything was perfect. I checked the occlusion myself, and patient was always complaining that I had a problem. And that patient came to me for almost 7 years for a follow-up, eating with that tooth, but saying that she had a problem. Okay. Always I used to listen to her. I used to counsel her. I used to do some kind of placebo treatment and send her back. And after 7 years, I didn't she didn't make a follow-up with me. Okay. But I am sure that it was doing fine. That's why she didn't come to me. But 7 years, I would say that was psychological failure. Again, those biological failures, they can be classified into caries, pulp degeneration, endodontic, periodontal, tooth perforation, subpontic inflammation, occlusal problems, general pathosis, mechanical maintenance failure. Mechanical failures can be connector failure, occlusal wear, tooth fracture, porcelain fracture, loss of retention. Aesthetic can be immediate or a delayed. Immediate fractures, immediate really patient didn't like it. Okay. Delayed, either it is chipped off or some other problem. Psychogenic is lack of counseling. Okay. Most of the reasons are lack of counseling, where you're not able to convince the patient. Patient comes to you, say, कि डॉक्टर साहब खाना फंस रहा है, and you know that it is a pontic area, खाना फंसेगा. The food lodgement is going to be there, but you didn't inform the patient prior कि yes, it is going to be there. Okay. So always try and tell your patient that food lodgement is going to be problem in this areas where the pontic is there. Try to give a modified lab only. Don't try to give a settled pontic. Okay. So biological failures, caries that can be due to marginal leakage, incomplete removal of caries, or oral hygiene. That is, caries index is very high. Okay. So if you are having a caries index which is really very high, okay, the FPDs might be, FPD, I want to say the bridges might be really contraindicated. Go for implant. Okay. Try to convince the patient for implant and say to it that, you are having multiple caries. And if I give a bridge to you, and tomorrow if you develop a caries under the abutment, okay, then you will be in trouble. I'll be in trouble because you have paid me. Okay, it's better that you go for implant and the individual tooth be individual tooth. So that if there is a problem with the individual tooth, if there is a caries, then we can go ahead and do a RCT and a crown on that. Marginal leakage is a big problem. Okay. Uh, Try to maintain the consistency of the cement while you're luting. Okay. Try to use the auto mixing one. Okay. Now these are the caries under the abutment teeth. Caries under, I mean, these are really very fatal when you take it out. No, that time you come to know. You just cannot see it on X-ray. Okay. So this I had cut a tooth and then I came to know, this is really gone bad. Okay. And there is nothing now. This is gingival polyp. I'll have to remove the tooth, place the implant. Patient you cannot convince because you didn't, convince it prior. Psychological counseling was not done before. Again, this is a failure in treatment planning, I say, because if you see, I'm sorry, this poor photograph, this was done by one of my students and this was given to me, but I wanted to put this picture because if you see that there is a canine and then those two premolars are missing. Okay. On the other side, there's a premolar which is there. Okay. So if you are having a canine and if posterior to the canine also tooth is missing, anterior to the canine also tooth is missing, don't go for FPD. Okay. Try to not make a pyre abutment. Okay. Always try to give a anterior FPD or a posterior FPD to the canine. Okay. Don't go involve canine to the pyre abutment. This will not get successful. It's a failure in the planning only. Again, aesthetic failure basically. Okay. So this patient, multiple perforations are there. Again, aesthetic failure. Okay. Again, patient came to me. I removed everything. I did a root canal and you can see the central size are there. Then these are two canines and the lateral sides are missing and there are only two molars are there. Okay, so I placed the fiber post there. Okay, you can see that and you can see the transformation now. It's going to be really great. Okay, so here it is. Okay, so this is a beautiful one. Endodontic problem, provisional restoration not placed. Patient was complaining of sensitivity. You didn't place an provisional restoration. Patient is going to tell you, for entire, time till the time his pain is relieved. If it is normal sensitivity, it will really take back. But if it's going for pulpal degeneration or reversible pulparitis, you're going to remove the crown, then you do RCT, patient is not going to pay you back. Okay. So place your provisional restoration. Okay. Perforation of FPD, very common when you are not preparing, your tooth properly into occlusal areas, thinking that, the tooth is going to perforate, the pulp is going to expose, so you don't prepare the occlusal area, then these problems are going to occur. Luting failure, galvanism, not common. Okay. Coolant, we don't do, overheating. I mean, I'm sure that everybody is using a good amount of coolant, but endodontic problem can occur if you do that. Okay, this is the perforation. You can see. Diagnosis of perforation is very, it's not very easy to do that. Okay. So, be very keen when patient is going to come, you dry the area totally and then see. Okay. Patient is just going to complain sensitivity under the tooth. Okay. Now, that tooth was placed probably 2 years back. Okay. So you are supposed to see the purpose of why the sensitivity is happening. Just don't prescribe any anti-sensitive or desensitizing toothpaste. Just look for that area keen in a very controlled way, and then come for a conclusion whether you should provide desensitizing toothpaste or you should go for a removal of crown or repeat the crown. This is again a perforation. Parental problems, they can be local factors. Local factors are in your domain. If you're not done a good FPD, okay, or a patient is not brushing from that side properly, or general origin, that can be due to the systemic diseases also. Okay, local factors are over contour, poor margin adaptation, interdental hemorrhages, pontic or poor design, poor polishing or rough surface. This is very common with the local lab. Encroachment of the biological bit. We discuss all them. Okay. So this is a root canal treated tooth, and this is miracle mix was done to the patient. A crown was given. My postgraduate student told, sir, I have given a good crown. I also saw that, it's a crown. And then I asked him to take a pic of it. And then I called him to my chamber. We enlarged that pic. And when we enlarge that pic, you can see that we are short with the margin. Okay, we are way, way short with the margin in this direction. You can see here, the margin is here, and we are to. This is definitely going to be, this is under contour. It is not over contour. This is under contour. So what will happen? This area is again prone for the caries. Okay, marginal integrity. Well, there is a process in this truth. Okay, and restoration margin should be closely adapted to the cavo surface finish line of the preparation survival of the oral cavity. Now, if you can guess, this is the crown which I had given. Okay, and I show the bubbling effect of it. You see the air bubbles? I just slide it. The air bubbles are going to come in. If your air bubbles are going to come, it means the adaptation of the margin is really very good. Otherwise, the bubbling will not be there. If it is open MS, if it is, the tooth to the restoration, okay, that distance should be somewhere around 25 to 40 microns, or not more than 80 microns is not acceptable. Okay, so the intimate fit of the processes to the process to the abutment tooth is really very, very important. Okay. Okay. So this is again a faulty processes, and you can see there is a good amount of encroachment of biological width. I hope you really understand what is biological width. Say over contoured bridges leaving a gingival trauma and periodontal disease. Okay. So let's see what is biological width. This needs a very good discussion about it. Okay. Gingival sulcus is 0.69 mm. Okay. And then you have a junctional epithelium of 0.97 mm. And then you have a connective tissue of 1.07 mm. Total, it will come to somewhere around 3.04. Sorry. Now, while we are giving a margin, while we are finishing a margin on the road, we are not supposed to go beyond zero point 0.2 mm of this area. We want to hide our margin. We can't place our margin in this area. We cannot touch the junctional epithelium. If you touch the junctional epithelium move down. The connective tissue will further move down. This bone is going to resolve, and that's why it is called as biological bit. Okay. So this is 2.05, 0.97 and 1.07 is somewhere around 2.04 mm. Okay, this 2.04 mm is really very, very essential area. Don't touch this area. The moment you touch this area, the crestal bone is going to resolve and again is going to maintain its biological width. So biological width is called as because it maintains its width automatically, biologically. Okay. So if you're going to gingival sulcus, just do the gingival retraction, place your margin 0.2 to 0.3 mm. You want to just hide your margin. That's all. Okay, the 0.2 to 0.3 mm is good enough. If you go more than that, the gingiva is going to recede. So initially you will look that, the margin is hidden, but just after a month or two, you see that the margins are really exposed. Yeah. These are the, temporary should be like permanent. See the margins, they are really good. They are not going, beyond the tooth. Okay. This is the rough surface. You can see this is the rough surface. They are potential areas to, where the plaque accumulation is going to take place. So now patients are going to have a lot of false smile. You can even see the pontic is not good. Neither it is saddle, neither is it modified lap. Okay. Yeah. See, the supraindial finish line. See the finish line. See the lab, how nicely lab has made it, and how it is fitting in the patient's mouth. You chose that margin. You chose that supraindial margin. I 90% of time I'll choose supraindial margins because they are easy to maintain. I don't go to gingiva unless patients are really highly aesthetically demanding, or the patient has a lip line which is very in the particularly anterior teeth. Occlusal disharmony, premature contact, TMJ troubles, pulpitis, occlusal schemes, they can be, provided to your canine guidance, unilateral balance, bilateral balance occlusion. Okay. Bilateral balance, we don't give in FPD, so there's no question. Unilateral balance, okay. When the patient moves towards your left side of the jaw, all the left side teeth should meet and right side teeth should not meet. If the only canine is meeting, that is called as your canine guided occlusion. You should avoid premature contact because premature contact is coming. Patient move on कर रहा है and he's saying कि मेरा वही दांत मिल रहा है. Okay, definitely is going to give you TMJ problem. Definitely it is going to give you pulpitis. Definitely if you have done a root canal to that particular tooth, patient is going to complain on the pain in this area. Okay, so Ocular disharmony is really very, big contributor to the failure of FPD. And when it is not controlled properly, it will give you severe pain, and, tooth can go for extraction also. Tooth perforation, less tooth structure like lower central incisors, you should be taking care of it. Okay. And control your taper while you're doing it. Too much of taper to compensate for the path of insertion, that again results in a lot of failures. Okay. I'll show you with an example. Again, tooth perforation, it can be, during your endodontic treatment also it can happen. It can happen due to while placement of post-dent core also. Very, very common. Very, very common. You see this photograph, it seems to be fine. Okay. But when you change the angle, the post was going other way. Okay. And post-dent core failures also, there is a list of failures, and you see this taper, the huge taper. I don't know what was trying to control that, they perforated this, and first of all, you'll have to control the taper. Just try to give or 90 degree, you keep your handpiece always at 90 degree to the occlusal area. If you do that, you will not have any failures. You can easily control your taper if you have chosen a right burr also. Okay. Don't try to give a taper which is unplanned. You plan your taper. Okay. Always take a diagnosis. Initially, if you are doing an initial practice, always plan your taper in your diagnostic cast. Okay. Don't just try to jump on the patient aya and we start preparation on the tooth. No, don't do that. Okay. Take a diagnostic cast, patient go recall karo, tell that, that will help in creating a, temporary to you. Don't jump on your cases. Okay. And these perforation, if in case the perforation is occurred, perforations might occur. If you're doing a prep in a molar and the short clinical crown is there, and it's not root canal treated tooth, the perforation is going to happen. So, you convince your patient, see, it has happened, now we'll have to do a root canal. Be calm, be cool, and just manage it. Mechanical failure, loss of retention, connector failures, occlusal wear, tooth fracture, porcelain fracture, cementation failures. So these are so many fractures. Loss of retention, basic reason will be long time bridge. If you're giving a long span bridges with a heavy occlusal contact, always you will have a loss of retention. Second is short clinical crowns. If you are having a short clinical crowns, you should know how to manage it rather than just giving a crown on it or doing a crown lengthening on it. Give a multiple grooves. Okay. And, if you have a very intimate fit with the crown, the short clinical crowns are very easy to manage. They are not really very difficult. And don't depend on the strength of the cement. Depend on the mechanical which you introduce in the abutment tooth. This already been, explained to you. You cannot give this three-pointed design. If you give a three-pointed design, the flexure is going to be 27x. Okay. And long span bridges facing higher occlusal forces, they will lead to micro leakage, secondary caries, and definitely, ultimately, because of micro leakage, secondary caries will happen. Because of secondary caries, loss of retention going to happen. Ultimately, the bridge is going to fail. A patient came with 3 tooth missing, now he'll have 5 tooth missing. Okay. So try to give 2 implants and a bridge. This is a short clinical crown. See, this is the arc of rotation. When you have height, which is really very good, this is the, you prepare it with this, and this is your arc of rotation. Okay. So when this is the arc of rotation, the FPDs cannot come out. But when you have short clinical crown, see the arc of rotation, see this from this finish line to this finish line. Okay. So this will contribute to your arc of rotation. This can easily come out. So how do you shorten it? Just introduce a groove. The arc of rotation will shorten here. The FPD just cannot, come off from one area to this area because there is a groove in that. Okay. So it's an anti-rotational feature also. Okay. I mean, this is a short clinical round. The taper is not controlled. The groove is not given. And it is being used for FPD. Definitely you will have failures in this. Loss of retention, again, diagnostic criteria, cold and sweet sensitivity. Okay. Patient will come with typical this feature. Halitosis, patient might say that, I'm having bad smell. Patient sometimes will say that, when I eat, I feel that there's a movement. And when you see, you don't find it. Okay. Press it. You'll see the bubbling somewhere. Okay. See, this is how you see the bubbling. Okay. Cementation failure and loss of retention. If you press that area, you'll see the small bubbles coming out. Connector fracture. Okay. If you do a shoulder joint, we don't do shoulder joint. Okay, so that is not a failure right now here in India. Cantilever joint, that is double abetting, deep overbite, and poor planning. So cantilever joint should be avoided most of the time. If you are doing cantilever, increase the area of your uh, connector. Okay. So this is your, double abetting. This is called a double abetting. Okay. When you use the two abutment and you given a pontic posterior to it. Okay. Sometimes it is done with a, when the molar is missing. So Bernard Smith writes that, you can give again a premolar to, if your molar is missing, you can use two premolars and give a premolar and the posterior region, and your premolar should be infraocclude by at least 0.5 mm. Okay. But that is his thought process. It's not very well documented. It's not very well researched. So don't do that. Okay. So what will happen long term when you apply a pressure? This pond is going to fracture. So how do you reduce it? You can, increase the size of the connector. The moment you increase the size of the connector, okay, the food volume is going to more. So avoid it. Don't do it. Okay. So place an implant instead. Okay. Occlusal wear, heavy chewing forces, very, very common. Patient coming to you after 5 years or 4 years and say ceramic is gone. You should be able to predict it better. Okay. Don't try to promise a patient a zirconia. Zirconia will not fracture or 5 years, you have guarantee. Simply go for a metal crown. Simply go for a metal crown. Prefer a metal crown in a very heavy occlusal forces are there. Okay. That will lessen your burden, lessen your failures, and your failures are less, your clinical patients will increase more. Patient is a bruxism or a clencher situation or a thin metal thickness, again the occlusal wear is going to be more and the perforation is going to be more. Okay. And try to buy a metal gauge. Okay. Metal gauge is there where you can, snap across and you can, it's a gauge where you can measure the metal thickness. So before you start trimming the metal or before you start trimming any crown, just measure it, how much it is. Okay. If it is less than 1.5 mm, don't trim it. Okay. You prepare, either you can do some kind of enamelplasty in the lower tooth. You can adjust it to, the only enamel is there. You can adjust it to 0.5 mm, not exposing the dentine. But if it is more than that, go for a metal crown, or you modify the abutment again, make a impression again and redo the crown. Failures which is coming later on cannot be, you planned your failures then. Tooth structure, inadequate tooth structure left after the preparation. Caries not removed properly. Heavy occlusal pressure. Okay, this is again, this is our planning failure. Okay, tooth fracture due to undermined caries or insufficient tooth structure left. Porcelain fracture, high point. Okay, or a sharp, tooth which is projecting out from the lower one and it is hitting the ceramic again and again. Okay, round off the opposing tooth. Always round off the opposing tooth while you are doing a ceramic restoration or zirconia restoration. And if you're doing EMAC, okay, please round off the opposing tooth. Inadequate clearance, your failure. Porcelain porosity crack, it's a lab failure, but you should be able to diagnose. Please screen your restoration under the white light. If you, sorry, your light your gun, just see your restoration. You will be able to see this porcelain crack. Okay. Before putting the patient mouth, when the lab comes, just teach your technician, just show him one crack, and he'll be able to easily screen it. Poor adherence to metal with porcelain. Okay, that is again a lab failure. Poor designing of metal structure. Again, that is a your lab failure, which was chosen by you. This fracture, what happens next? Okay, it's a functional cusp which is gone. Okay, to remove this kind of FPD is easy? No, it's not easy. Okay, so it's better. See, the failures occur from ceramic to ceramic. Okay, then ceramic to metal also. Okay, so it's a failure where patient was actually, what I think is a clenching. Okay, or he was a heavy bruxer. Okay, so these kind of failures can be avoided. Yes, it can be avoided. Just modify occlusion. Okay, just make sure that eccentric occlusion was not coming in contact with this tooth. When patient is going to move from the left hand side or right side, make sure that these more of the teeth are meeting. Okay, not only single tooth is meeting. If the single tooth is only meeting the opposing tooth, then this kind of failures are going to occur. Now, these are again a porcelain fracture, very rare. This kind of things are going to happen. Must be a patient fault. You can repair it. You can put a organosilane and You can put up your sometime metal exposed. You can put a metal masking agent, and then you can put a flowable there, and you can finish and polish it. Cementation failure, cement flow and cement thickness, very important thing. Very important thing. Biting pressure, if not maintained, again it is the fault of patient. But try to make the patient sit in your clinic for 10 minutes at least. Biting pressure is maintained there, because patient, the moment patient goes out, he wants to talk to everyone. Cement remaining in gingival sulcus, very common cause of failure. Cementation method, choose your cementation method properly, whatever method you are using. Okay. Thermal sensitivity after cementation, well, then the patient root canal treated tooth was not there, and you are just openly drying that tooth and desiccating the dentine. Thermal sensitivity is going to be there. Okay. So this is again a crown. This patient of mine only. Just came to me after 4 5 years, and I saw that your nice little cement was sitting there. Though I had given a very good cast partial to the patient, patient was wearing properly. Okay, but this is my failure. This is my created failure. Though patient didn't have any trouble, I removed this cement very easily. Okay, but uh, this was my failure. Aesthetic failure, shade mismatch, incorrect contour, metal color exposure, and gingival recession. Now, these are the major concerns for each and every private practitioner, that shade mismatch. Okay. So shade mismatch is a concern for everyone. Okay. If it is a PFM restoration, don't try to match the shade much. You will not be able to do it. If it is all ceramic, just stick to the guidelines. Just stick to the guidelines. And if you feel a reference, take it from your, the boy who is working as a dental attendant to you. Take his help also. Okay. Try to take his help, and always, try to, convince the patient also that we have taken this shade. Okay. So that patient doesn't complain later on. Secondly, if I have to really say, that you close your eyes for at least 10 seconds, and you should be able to match the shade within a 2 second window. Okay. If you're choosing a shade as a A2, okay, take the tooth to the nearest, to the adjacent to the tooth of the natural tooth of the patient. Okay, close your eyes for 10 seconds, just open in a snap, and decide both the shades. And look on the middle part of the tape, shad tape. है ना, शेड का जो टैब होता है उसके पार्ट पे आपको देखना है. Okay, so that you're able to see that. Okay, so that is the easiest way of doing it. Okay, if you take a longer period, the accommodation effect will happen in the eyes, and both the shades will look almost similar to you. Okay, though there was a shade difference. Metal color exposure. Okay, I had told you, if you are doing, if you are going subgingival, and if you are going more than 0.3 mm, the metal color exposure is going to happen. Okay. Midline not properly placed, interdental papilla, hemorrhages. You have not planned it. We'll see that black triangle is seen, or contact point not properly designed. These are all, the failures which were done by lab but accepted by you. Okay. You see the intent papilla, we are encroaching it. Okay. This is not going to be very, happening for the patient for a long term. Patient is going to come back, and patient is going to come with a lot of gingival inflammation later on. Okay. This is the black triangle, you see. Okay. So this is also not acceptable by the patient. Again, I had told you the patient will come back. See, this is gingival inflammation which is occurring. Okay, both the sides. So don't try to encroach the, gingival area, internal gingiva. Don't try to pressurize it. Okay, it will not take it. If you have having a restoration like this from the lab, and if you can't send it to lab, then you should have efficient amount of measures to adjust the crown on the chair side. Metal collar exposure, problem can be gingival trauma, wrong choice of metal and porcelain. Solution, colorless porcelain fused to metal, that is 360-degree, your ceramic margin, okay, or all ceramic restoration, okay. But labs do not make it, 360-degree PFM, that is shoulder porcelain. Many labs are not making, because those porcelains are totally different, okay. And if the good labs are making it, they are charging you more. So again, this is a discolor tooth, and this is a FPD. Gingival recession, that is gingival trauma, cervical overcontour, periodontal problem, thin gingiva. Thin gingiva is a big problem for you all. Thick gingiva can be easily managed. But thin gingiva is really very difficult to manage. Post-incision problems, cold response, hypersensitivity, heat responses, pulpal hypolemia, it will definitely go for a antidote. Discomfort during function, premature contact, percussion reaction, that is periodontitis or pulpitis. Gingival inflammation that can occur due to rotary cutting instrument trauma, excessive tissue retraction, cement and gingival sulcus, and poor oral hygiene. You can see the gingival trauma. Okay, give a good restoration. See, this is a very, horrible retraction which was being done, So, if you are ending up, if you are doing a gingival retraction, the gingiva is going to recede like this. Okay, though it is a thick gingiva. Retention of food, tongue and cheek biting. Okay, the patient, commonly comes to you. You should have maxillary teeth which are always outward. If you are having, otherwise the mandibular teeth are outside and maxillary teeth are inside, you're going to have the, cheek biting. Okay, so try to, if you are landing up the patient occlusion is not good, okay, don't try to give edge to edge. If you try to give you edge to edge, it will always land up in trouble. Sweet sensitivity, indications of your cement dissolution, your loose retainer, and your caries. Tooth mobility, improper crown to root ratio or a faulty selection of abutment, again, poor oral hygiene. Neuromuscular pain, definitely occlusal distress is there, or other systemic problems are there, or it can be psychogenic also. I'll show you some good cases now, which are really, messed up cases. Okay. And this was done by dentists, okay? They were not done by quacks. The FPD was, ring class was given using, ring class cannot be given by a quack. Okay. And that was used for a cementation purpose. This was the entire FPD which was given. I cannot assume a quack doing that. Okay. To break it open everywhere. Again, a classical failure, I have heard a restoration of metal along with acrylic or a metal with PFM, we have already doing it. So metal with acrylic, we do with hybrid processes. In this, all three were there. Metal is also there, acrylic is also there, ceramic is also there. See this. Anterior teeth is with your this thing, and posterior teeth, and they were all cemented to your, four teeth. Okay. And these are the four abutments which were used. Okay, this was cemented, and the entire process was resting on the ridge. It will not retain. It will come out in a loss of retention is going to be there. Okay. Case 3. This was, I think, done by a quack. Case 4. This was a case which I had shown you. Okay, this was initially done by a practitioner, and then the patient came to me after 7 years. And for 7 years, she was missing. She was roaming around with this FPD. Then I removed it, and I did the case. This is again, see the, you see the OPG, you will understand the case. See how dignified, he had taken a support also from the, like a subperiosteal implant, a quack cannot do it. Okay. So these are the, you cannot classify into any kind of failures. The conclusion, fixed prosthodontic treatment does not end with a fitting restoration. It actually starts from there. Subsequent maintenance is an integral part of the treatment. If this is not done adequately, precise failures can occur. The first consideration when confronted with any failure is to research, ascertain the cause. If there is a cause that is correctable, it should be taken care of first. Failures most often occur of violation in principle, either collectively or individually. Care should be taken not to become involved in repair. Okay, it should be done in a first one to be done in a proper way. Repairs are usually the second best to the original one or more ways. Okay, most failures are unique and presenting very challenging to to the dentist. If you are having your failures, you still know what you've done. If you are having a failure from other dentists, it's more difficult, it's more challenging to manage. Treatment planning is really very, very important. Okay. I'll just show you good cases, 2 or 3. A patient came to me, and this is lab support I got, and this is the post. I mean, see the shade matching in this. Again, a patient came to me with a huge diastema. She was from Belgium, and she had come to me for lower CD. After 4 years, she returned back to me saying that, you can do something for it. She is 63-year-old lady. She told me something you can do for my upper anterior tooth. I said, definitely yes. So this was the gap. Okay. We did this way. Okay. So the gap is gone, and patient smiles good, and I have not increased the size of the tooth. Okay. So this needs immense planning. You cannot just do it. And I didn't do root canal. Okay. Again, an old lady, she wanted her teeth to be very perfect. So we gave her like this. Okay. She was happy. I had a follow-up 2 months back. She's doing fine. This was the starting case which I told you, it was orthodontic failure which came to me. She was very young girl. You can see that, see her smile, and we modified to this. From here to this place. I cannot do anything for this gingival recession. Okay. So again, from reaching from here to here is not easy. Okay, it needs a lot of experience, it needs a lot of control, it needs a lot of dedication towards the practice. Okay, put the money aside, just read and do a good job. So the step for success is only fail, and ultimately on your top you'll do a success thing. So if you are having a failures per year, your failures are there. It should increase or it should decrease in your clinical practice. That will be decided by you only. Okay. So thank you. I'm ready to take any questions.
Thank you so much, sir, for the informative session. I would like to thank Dr. Anmol Bagaria, ma'am, Dr. Ashish Chandra, sir, for organizing this webinar series, and my co-moderator, Ms. Kadri. Also, thank to all participants who joined us today. Thank you, everyone.
Sir, we had a few questions for you, but you have answered almost all the questions through your presentation. Thank you so much, sir, for the wonderful presentation, sir.
Can you hear me?
You, sir. Yes.
Yes, sir.
Yeah. Okay.
Thank you so much, sir.
Okay, Beta. Thank you so much. Thank you so much. Thank you for the opportunity. Okay. So we end up.
Yes, sir.